So today we have a new video, and you know what we're doing with Shelly's Nursing Review at HETV on YouTube. You know what we're doing. We're making sure you are fully prepared for the NGN NCLEX exam, because the NGN NCLEX exam has changed, right? What did it do differently? Oh, it gave you partial credit. That's a good thing. And of course, it included case studies, and it's apparently obvious that you guys love case studies. So I always tell you, don't focus too much on case studies, because guess what? Y'all are doing well on that. When I analyze all the different reasons why you fail, it's not case studies. It's the stuff behind me. Yeah, so what am I saying? Well, I'm saying that this test has changed in two major ways that you're not handling very well. One is pharmacology. This test is putting way more pharmacology on for you guys to know, and that's a good thing. And I'm sure it has to do with quite a few things that have happened in the public, like Redonda DeVault not even knowing her generic medication name for Versed. To that end, do you know the generic name for Versed? If you don't, you're not ready for the real world, because you give Versed a lot. And that's how she killed the 73-year-old patient that she was taking care of. She did not know the generic name for Versed. So the test has chosen to put more medications on it so that you understand just how critical your role is in knowing the names and the indications and the side effects and the contraindications and complications of medications. Now, we know that medications, every single one of them has a side effect, but you've got to be real specific on some of these medications, right? And that was one thing that changed. The other thing that changed on the NGN NCLEX exam was that they added more infectious diseases. Now, from my analysis, and I'm working with that PhD, so I'm telling you, I know how to analyze, but I don't know how to do nothing else. And I've been divorced 17 times, so marriage, I don't do well, but I know how to analyze. So, not 17, but close. But so analyzing is my forte. So when I analyze all of these students who have failed this exam, what I'm seeing, and it is alarming and it is important for you to know, what I am seeing is that the reduction of risk is what people fail the most on the new test. It was kind of tied with basic care and comfort. If you'll remember the old test, I mentioned to you that basic care and comfort was the #1 area of failure. And now what I'm seeing is reduction of risk is the #1 area of failure. And what I tell you is to remember, what the heck does that mean anyway? Like reduction of risk. That's some $4 words if ever I heard any. It's all BS, because that ain't what we call it. You know what reduction of risk is? It's procedures. Yeah. IV, Foley, surgery, all kinds of procedures. Your central lines, your eardrops, your eye drops, your lumbar puncture, your MRI, your CAT scan, your EEG, your EMG, your Glasgow scale, your log rolling, your medication administration, different ways to put a topical on a patient, sitz baths. Yeah, all that stuff. And you already know we have pink packets for that. And you know how to get them. You just text me at 216-410-0936. But today's video is about pharmacology, specifically a medication that you have to know a lot about, and indeed, it plays a role with reduction of risk. And you'll see how I kind of, show that later on in this video. But this video is trying to explain to you what it is that metformin is going to be used for, like what is the indication, and then what are the side effects, how does it work, what's the complications, what's the contraindications. And so you will see this video that I'm about to do. It will be in the pharmacology playlist. So if you haven't figured it out by now, my playlist, and I'm going to say that over and over again in every video I can, if you go to my playlist on HETV TV. You have to go to the playlist because that's like the library of all 400 plus videos, right? And it's really organized. So if you pull up the playlist of psych and you tap on it, you're going to get a shitload of psych videos. If you tap on GI, you're going to get a shitload of GI videos. Think of the playlist as a textbook, and then you open the textbook and ooh, there's all the chapters. That's how my channel is organized. Very few people do that. I did that because I personally noticed how scattered all the videos were on the YouTube channel and how difficult it was if you liked this video to find more like it for the same person who you felt taught really well. And you know what I always say, I am maybe not the best, maybe I am the best, but I want you to also make sure you look at other videos, not just mine. No, I'm not selfish. I want you to really look at other videos. And I got good news. I mean, I don't know if you noticed, but I certainly noticed because this is the software that I recommend. The UWorld software has now put videos, and I'm talking about a ton of videos on everything. So if you're in my class, you know that your homework and your classwork and your work always involves looking at the videos. And you know that I told you when you're looking at psych videos on my channel, you better pull up the same damn thing on UWorld to reinforce your learning. And it's nice, it's a change. Now they are boring, and that's okay. You need to be bored sometime. Everybody can't be coming up here dancing and cussing and singing. So, you know, it's that, but you have me to go back on and laugh at, so it's okay. Here, we're going to get started, and I hope you are ready. You have to take good notes. You just do. And just so you know, the packets, if you already have them, that we're going to be taking notes in, diabetes, of course, you can use this and only this and still be fine, because look at the diabetes packet. One of the things you'll notice is that I prioritize what I want you to learn right up front in the packet. So in the diabetes packet is metabolic syndrome and Metformin. I try to organize my handouts in such a way that you have the disease and what treats it next to it. Okay? All right. So, however, you might also have this packet, and if you have this one and maybe you don't have the diabetes packet, you need to know that this packet is your medications that affect the endocrine system. And oftentimes it's not just diabetes medicine, but it's also thyroid and adrenal cortical and anti-diabetic. So this whole packet, and it's kind of thick, has all of your anti-diabetic medications. And so if you open this packet, you'll see metformin in it. So it's in more than one packet, but for now, let's get started. Now, what if you don't have any packets? So what? I always tell you to buy that big old 5-subject notebook and take really good notes. Have your shit categorized, put some titles up there. If I say a certain number of ways something works, you put that number in your notes. If I say this is a select all that apply, you put SATA by that note. Really make your notes stand out. Use your highlighters, use your colored pens, and let's go, okay? Enough about that. Let's get started. All right, so metformin. I have a couple of things that I like to share with you that actually help me. I don't do a lot of mnemonics or tricks because I find that you just confuse them all. But some things are really nice with a couple little, hints on how to remember stuff because you're human and there's so much shit to know. So look at this. Watch this now. Hopefully you got your little marker out and you're doing what I'm telling you to do. Here we go. Metformin treats metabolic syndrome, which also needs a Mediterranean diet, and the drug itself can have a metallic taste in the mouth. right? I mean, met is what I'm saying. So with metformin and metabolic syndrome, I tell you they're the M&Ms. So you got M&Ms, okay? So if you remember M&Ms, you should be fine, all right? So let's dive a little deeper, right? Now, so this metformin, you need to know 1 in 3 people in America are taking it. Yeah, it's the #1 drug first-line treatment for type 2 diabetes. #1. It's #1 for polycystic ovarian syndrome, PCOS, polycystic ovarian syndrome. It's also used to treat patients with the old-fashioned terms that you might see, insulin resistance, okay? So you have a ton of people with that in America, right? So you're gonna see this drug all the time, and you're gonna give it out all the time, okay? Now, so it's cheap. It's a $3 holla, meaning generic, right? So it's not gonna cost $1,300 like your little GLP medicine does. The little GLP-1 I talked to you about. If you don't know what that is, you better pull it up on the pharmacology playlist. Okay, we already said it's the first line. Now, I do want you to really pay attention to the other name for it, because your test is tricky. What if they put glucophage? What if the patient comes in and says they're on glucophage? Now, most of us say metformin, but just know that the other name for it is glucophage, okay? So you don't want to get caught up in just dumbness and forget the name that somebody comes in and says. Patients just know, brand names, and here you and I are, we have to know the generic and the brand name. Okay, so let's move on, shall we? We said it treats metabolic syndrome. Now, if you're thinking, Shelly, I never heard of that. I don't know what the fuck it is. What? You're okay, because it's not well known, but yet, get this, half of all 60-year-olds in America have it. Women especially are prone to it. Latinos suffer a lot with it. And so here we are with the condition that half of all 60-year-olds and up will have, and we don't know what it is. That's not good. You ain't learning nothing in that school. I know. So that's why your girls and your boys got me. Okay, so here we go. Metabolic syndrome, are you ready? I use this type of thinking when I talk about metabolic syndrome. I think it'll help you too. Remember that all the B's are high blood sugar, high blood pressure, high belly fat, or you could say BMI. Remember, body mass index. And don't forget what those normals were with body mass index. So if you remember that body mass index takes your weight and your height into consideration, you will remember that the normal or ideal body mass index is 19 to 24. Yeah, you might want to write that down. 25 to 29 is considered overweight. 30 and up is considered obese. But then 40 is considered morbidly obese. So this patient with metabolic syndrome is often called pre-diabetes, and because it's not full-blown type 2 diabetes yet, but there's a lot of things going on that are very dangerous and can be deadly for this patient. So what we have is we have that high blood sugar, and so you're gonna have a patient, and you gotta remember some of this stuff, you're gonna have a patient where their fasting blood sugar, don't forget I said fasting, their fasting blood sugar is higher than 100, or their regular blood sugar is over 126. Specifically, their sugar of 200 and higher is very suspicious for somebody having some type 2 diabetes or something going on metabolically. So I do want you to remember, out of all of that 100, right? That 100 for fasting blood sugar. Your blood sugar should be less than 100 fasting. You went all night and you didn't eat, and I come in there in the morning, and well, I'm not going to come in there unless you need me to help you, but our medical assistants or our nursing assistants usually get our blood sugars. We are blessed to have them. Sometimes you don't, or you get one and the other one called off. So guess who's going to be doing blood sugars? You're behind. So when you, me, the medical assistant, the nursing assistant, the PCNA, whatever the hell they're called at your hospital, when they go in to check that blood sugar right at 7 to 8 o'clock, that's considered the fasting blood sugar. That's the one that needs to be less than 100 for us to be happy, okay? Now, so it's only checked on diabetics, so it's never gonna be less than 100 usually, but you just need to know that for your test, okay? Then don't forget the hemoglobin A1C. Now, I see that you guys kind of forget how this plays a role, and you gotta remember what I said in my diabetes lectures, which is that the A1C is not dependent on when you ate. It's whenever. I could do it whenever. You could eat a Snickers bar and I could do it. It'd be very accurate. Because what is it doing? Well, let's make sure we know the words, right? Hemoglobin A1C, also called on your test glycosylated hemoglobin. Glycosylated hemoglobin, glyco, what is that? That's sugar. So sugar attaches to the hemoglobin. And if you remember red blood cells is another way of saying hemoglobin and hematocrit. So if sugar attaches to the red blood cell, the hemoglobin and hematocrit, and the red blood cell lives, as you know, for 120 days max, so some die off sooner, but they live for 120 days, then you now understand why if I take your blood and look at your hemoglobin A1C or your glycosylated hemoglobin, which is the other name for it, I can determine how your sugar has been on average for 3 months at least, right? So 3 months, which is 90 days, is what I can kind of look at that blood test and say, geez, they've been riding about, 200 or 300 every day for the last 3 months based on this A1C. Now, what is metabolic syndrome? Well, it's like a pre-diabetes. So remember the definition of diabetes and a hemoglobin A1C is 6.5 and higher. So type 2 diabetes, well, any diabetes is not diabetes insipidus, but any diabetes mellitus is going to be, again, I hope you heard me, 6.5 and higher. This patient is pre-diabetes, right? So they're going to be 5.7. Yeah, you got to write it down. 5.7 to 6 point what? 4, right before you get that whole 6.5, I got diabetes, oh my God, what am I gonna do, oh my God. Okay, so again, metabolic syndrome is a high blood sugar. So come on, let's do more. It is also a high blood pressure, but again, this is a lot of pre-type stuff. So maybe you were taught that high blood pressure is about 140s over 90s. To be metabolic syndrome, the patient only needs a 130s over 80s because we now recognize that 130s over 80s is not normal. Hello. So if you're 130s over 80s and you run around here with insulin resistance or a higher blood sugar than most of us, well, I mean, some of us, I guess, then of course we're concerned because these two together are bad, and then you're going to add some more. What is the number one symptom of metabolic syndrome? Number one, like it's more reliable than the blood sugar, the blood pressure, all that. Belly fat. Yes. For the female, this is an abdominal circumference greater than 35. For the male, this is a abdominal circumference greater than 40. Now, I'm old school, and I don't know if you remember the crap I remember, because some of y'all are so young, but there used to be a R&B, rhythm and blues group called the Commodores, and they had this song called Brick House, and it said in that song, oh, she's a brick house, well put together, everybody knows. Now, what numbers did they think was a brick house measurements for a female? Well, they was a little extreme because I don't think I ever was them measurements. They called it 36, 24, 36. What a winning hand, y'all. She's a brick house. What was the 36, 24, 36? What was that in that song? Well, they considered a well put together lady to be 36 in the boob area. Let's just say nothing wrong with a little plastics in that department, okay? We'll just leave it there. I ain't gonna say much else. I'm gonna just let that sit there for a minute in the wind. Okay, so 36, 24. Now, wait a minute. 24, Shelly? They were talking about a waistline of 24. Yeah, these motherfuckers was talking about a waistline of 24. Now, I ain't never had no 24 long as I could remember. And if I did, I was somewhere around 10 years old. But my point to you is they were saying 24 for the waistline. What did I just say? I said metabolic syndrome has a waistline greater than 35 in the female. And here you're talking about the most sexiest woman is running around here with a 24. Now, what was the 36? That was the hips. The breasts and the hips do not play a role in metabolic syndrome. Don't be screwed on that test. Only the waistline of 35 and higher is metabolic syndrome. This is called belly fat. The fat around your belly is going to cause you to have really a terrible time making your organs work, and they have to work extra hard when there's all this fat pressing on them. In particular, your heart, your liver, fatty liver, right? Yeah. So the fat in your midsection here is going to cause your body to work harder at its main functions. It's not good. It's called a couple things on your test, right? So if you're taking a HESI, an ATI, an NCLEX, a PA test, an NP test, no matter what test you're called, it's not like the body changed because you're taking a different test. If you're taking any of these tests, make sure you know all the language. It's either called truncal obesity or central obesity or visceral fat, or when you're talking to your patient, good old-fashioned belly fat. Okay, so that's this. Look what you got so far. B, high blood sugar, high blood pressure, high belly fat. The next two things are very important for cardiovascular health. And so those labs include triglycerides and HDL, high density lipids, right? So watch this. In the patient with metabolic syndrome, their blood sugar is high, their blood pressure is high, their belly is fat, and they have high triglycerides and low HDL. Now be careful, everybody. I do have a mnemonic that I think is worthy of sharing for this, because you kind of been fed a bunch of bunk when it comes to cholesterol, and I want to make sure that we know the real labs that matter, because over the years there's been some focus on LDL, and your test may even have a couple questions on the low down dirty dog, LD, low down dirty dog, LDL. It's a bad thing, right? Okay, but really, honestly, the worst thing, are you ready? The worst thing, I said the worst thing is triglycerides being high and HDL being too low. Now, how will you remember that? I have a perfect way. I came up with this years ago, probably 30 years ago now, but you gotta really listen. Okay, so here we go. I came up with this mnemonic. Capital H, capital L, capital T, periods after each one. You have to go over here and start there and move back for your blood lipid panel. When we do a lipid panel, we're going to get all four of these. So let's talk about what they are. This T way over here is total cholesterol. And what I want you to do is write the number right by the letter. It should be less than 200. Now, if you forgot how to make less than and greater than signs, you're not alone. I was quite grown when I you know, looked at that and thought, I don't know what the hell, which one is a part. This is a nice trick. The less than sign looks like an L. L for less than. That was for free. Okay, so I don't know who's out there like me, but I was kind of confused about that for a long time. So the total cholesterol, and you kind of knew this. This is not your first rodeo. You knew that cholesterol needed to be less than 200, right? I mean, come on now. But then what you have to do is you have to go down by 50 each time. Y'all ready? This one is your triglycerides, and it needs to be less than 150. So what did we do? We went from 200 down 50 to 150. Okay. Then we said that this low down dirty dog, LDL, needs to be less than 100. What did I do? I went down by 50 each time. Total 200. Triglycerides 150. LDL 100. H. Now the mnemonic itself is highlight, because I'm always yelling at you about highlighters. Highlight, right? That's the mnemonic, okay? I don't do a lot of mnemonics, but this one is a good one. Okay, now let's look at that H. Some of y'all are overjoyed, especially in my state, that the law passed that you could go ahead and smoke your little reefer without getting arrested and handcuffed and slammed to the concrete. Yeah. So now y'all happy and high. So is this. Here's what you want to remember about HDL. HDL is happy, like your ass, when high. Now that's important, because if you'll notice, every other one of those values had to come down. We need them lower or less than those numbers I wrote. This one, we needed higher than the number I'm going to write. Now, if you've been paying attention, you went down by 50 each time. 200, 150, 100. Where we going, y'all? 50. So this needs to be higher than 50. OMG. Listen to your girl. The patient with metabolic syndrome has a high blood sugar, high blood pressure, high belly fat, high triglycerides, and a low HDL. Their triglycerides are higher than 150. Their HDL is lower than 50. Okay, y'all. So what I'm telling you is when this patient has this type of syndrome, they're going to be treated with metformin. And it may not say metabolic syndrome anywhere. It may say pre-diabetes. It may even say insulin resistance. You have to know all the names, okay? So here we go. Now, when we look at metabolic syndrome, and we look at the fact that it's called insulin resistance, you have to remember something on every test, but this is more important for you to remember in the real world, because you are an educator the minute you decided to become a nurse. Metabolic syndrome, if we can catch you in the metabolic syndrome phase, the pre-diabetes phase, it's reversible. And guess what's more powerful than metformin? Because you know me, I'm a girl with very little drugs. I don't do a lot of drugs, okay? It's a lot of side effects with drugs. I don't like them. So what can we do to reverse this without medication, right? Well, Mediterranean diet, which is in your Oh My God packet. We can use intermittent fasting. We can get better sleep, because when you don't sleep or you work night shift, you get metabolic syndrome real fast. We can use a lower carbohydrate diet. Some people like keto. It doesn't have to be keto. Just cut down on the carbs. Specifically, stop drinking pop, fool. Okay? We can increase activity. Listen here. If you're door dashing your meal, that's not what I meant by increased activity. Because you should have got your little ass up and at least got to the car and went and got it, okay? So increasing activity does not have to be aerobic activity. No, you don't get to spend an hour on a treadmill. What your ass need to be doing is lifting weights, or like I do, planks, or like I do, push-ups, right? Or like I do, stop taking that elevator and use them steps. Park real far in the parking lot and take the steps. Listen to me. Strength training, weight bearing is better than aerobics for this condition. And work on trying to get rid of some of this weight, right? Because obviously obesity goes with this disease. I mean, it's common sense, okay? All right, now, so that's that, because this is not a metabolic disease lecture. It's actually a metformin lecture. So let's carry on, shall we? Here's our deal. Watch this. You absolutely have to know how it works. And one of the things you cannot go to any test with is believing that this is like your sulfonylureas or some of your other medication, where if you take those, they actually lower the blood sugar by increasing insulin production. You have to know that this is a PO medication taken by mouth, so there's no way in hell a type 1 diabetic would ever take it. You have to know that this medication that you take by mouth is going to be given in a way that we titrate the dose and we go up slow, at least the doctors that have a clue do, right? So we kind of start low and slow and go up as we go. Okay, you have to know that this medication could be given alone, or unfortunately for some people it doesn't work after a few years and it may have to be combined with another medication. But one of the main things I gotta get across to you is in red writing on my board. How does it work? Remember, it does not cause hypoglycemia or low blood sugar. In other words, it does not, like those other medications, sulfonylureas and different things, it does not lower your blood sugar. That's similar to the GLP-1 shots that people are getting for weight loss and diabetes. That drug didn't lower your blood sugar either in a way where we're worried about hypoglycemia. It acts on the body to better utilize the glucose and the insulin, but it doesn't just outright cause hypoglycemia. Now, that can change if you take this medication and you combine it with other things, so be careful. Now, let's look a little deeper, because I got 4 little things that you got to know about how this damn thing works. Did you hear me? I said 4. 1, 2, 3, 4. I hope you wrote down 4. Here we go. In the liver, it decreases production of glucose. You may or may not know that everything you eat goes to about 4 different places, right? So immediately the sugar in the food, if you ate any sugar, immediately the sugar in the food, the carbohydrate, goes to the brain. So you can think smarter, right? For now, because, you know, fight or flight might be going on, you need to think, okay? It also goes to your intestines, and it goes to your muscles, and it goes to your GI system and the liver. Now, it ends up in the liver so that you can store it as glycogen later tonight when you're not eating. And if you should go a while without eating, that is God's magical way of backing up your sugar stores, having it stored in the liver. The liver stores about 8 to 12 hours worth of sugar while you're sleeping and does quite well with that. Okay, so this medication decreases the production of glucose by the liver. It decreases it. Okay, so you don't have that available, so you may have to pull it from somewhere else. It also takes the intestines, specifically the GI system, but the intestines, and slows the absorption of glucose in the actual intestines. And that's kind of important because we know that many patients are eating so much high fructose corn syrup and sugary products and processed food that they're causing the flora in their GI system to be a piece of shit, literally. And so that flora is causing inflammation and making you very, very sick, right? Well, the good news is metformin does improve the flora because it doesn't allow you to absorb the sugar. And remember, bacteria loves sugar. So if you're not able to absorb the sugar, well, then this horrible flora, this bacteria-filled flora, will not thrive. So that's kind of a good thing. For the muscles, it increases the efficiency of the uptake of sugar. It increases the efficiency of the uptake of sugar. However, the problem is later down the road, we have seen some studies say it can cause muscle atrophy. Like, I'll show you what that looks like because I have Graves' disease and it can do the same thing. So look, I used to have really good Michelle Obama arms. Now it's just kind of like flab. What the fuck is this? This turkey shit. I don't know what the fuck that is. But anyway, that's a flabby arm. And that's what we mean by muscle atrophy. Because you're supposed to be like, oh, baby. Ooh, hoo, hoo. And I'm not. Okay. Now, so the GI is a big deal. And you know this because the GLP-1 kind of did the same thing, right? So what does it do in your GI? When I say GI, like it's so weird because you're like, well, what is that? GI, gastrointestinal. So if I say the word gastro, that means stomach outright. Just know that ahead of time. It slows gastric emptying. So what did it do? It slowed down how much food and how long the food is going to get out of your system. So maybe your food left the system, left your GI system in about 4 hours. May take 6 hours. You know, it just slows down the emptying of the gastric system, the stomach specifically. So the stomach is supposed to send the food to the intestines. And if you make it stay in the stomach longer, then you're not going to be hungry and you're going to be less likely to eat too much because you still have food there and you feel full, right? That word on your exam would be called satiety, right? Satiety. Satiety. Consider yourself lucky because I don't know if I spelled that right and I never spelled for you. So that was a once in a lifetime type of event. Okay, so all of the ways that this worked means a lot. Now look at this. I have here non-alcoholic fatty liver disease. What we're finding is that the metformin has shown to improve patients' situations with non-alcoholic fatty liver disease. Remember how I said fat belly or belly fat or truncal obesity or visceral fat or central obesity was a big problem because it can put pressure on your organs and cause heart attacks and whatever else? Well, this medicine does seem to have a nice effect on the fatty liver so that it decreases a little bit. And that's what we're looking at. That's a kind of a newer thing they're looking at and studying. So just know that, okay? So here we go. We talked about what it is. We talked about what it treats. We talked about the disease that it treats and the specifics you better know. We talked about that the reversal of this disease is actually diet, activity, and lifestyle, and it's more powerful than metformin, I might add. And we talked about how does it work. Now let's go over here and talk about the side effects of this drug, which is very different from adverse effects of a drug or complications. Side effects sometimes we can live with. Adverse effects are reasons to stop the drug. Complications, you know damn well you're going to stop the drug on that. So, you know, here we go. Side effects of metformin are directly related to, oftentimes in the initial beginning of treatment, how much we use and how fast we titrated it. So how fast did we go? Because what do we say? Start slow or start low and move slow, right? So here we go. Diarrhea is number one. So if you go in anybody's test and get this wrong, I swear to God, I'm going to slap you, cross your forehead, shank you in your kidney, punch you in your throat, and pull out your eyelashes one by one. Because everybody knows that metformin causes diarrhea. So what is our advice to the patient for this one? This is, again, let us know, because maybe the dose can be, put down a little bit, or, spread out or whatever. Typically the dose starts really low at 500 milligrams. And typically we start with, as you eat dinner, take this medicine, because we find that it's better when you take it with food. And we also want you to take it with the dinner and not the breakfast, because we'd like that medication that you took with the dinner, this medication, if you're going to have some side effects, maybe you're sleeping them off. See, because you're going to bed, shortly after dinner, not immediately, because that would be bad. But, so again, we try to tell you for these two side effects, the diarrhea and the GI upset. And when I say GI upset, we can run the gamut. Just queasiness, nausea, vomiting, diarrhea, just feeling like shit, abdominal cramping, my stomach hurts, that kind of thing. So both of these, again, take it with dinner, go slow, start low with regards to the dose, because a lot of these patients will work themselves up to 2,000 milligrams a day. And so a lot of them take 500 BID, which is twice a day, right? Or maybe they'll take 1,000 milligrams BID. So just, go slow, for crying out loud, okay? Let the body get used to this stuff, okay? Now, this side effect is really a nuisance. That would be, it can decrease the absorption of vitamin B12. Now listen to me. You know from my videos that vitamin B12 is needed, and it's in the geriatric videos, especially because they also have a low B12. Geriatric patients, the older they get, after 65 years old, their B12 decreases. And so for this, when I talk about a decreased vitamin B12 absorption, I'm telling you that that's kind of bad, because number one, it's associated with neuropathy, anemia, and even dementia. So we don't like that. We don't like that. So we want our patients to know to increase the vitamin B12 in the food, and almost all meats have vitamin B12, including salmon, right? So that's good. And then also many of these patients need supplements, but they just need to talk to their doctor to see what their levels are, because everybody needs their vitamin B12 checked if they're going to be on this medication. The other one that is really popular, let's just say you better write it down, is that metallic taste in the mouth, and that gets better after a few weeks of treatment. Another bonus, it's a side effect though, but it's a bonus because I don't know who's mad at it, is weight loss. The patient will lose weight. They will. They lose about 5 to 10% of their weight. So if you talk about the average female and you think about maybe she weighs 180 pounds, if you were to lose 10% of that, you'd lose 18 pounds. If you cut that in half and make it 5%, then they would lose about 9 pounds. So that's a plus, because that seems to improve all of the things in the metabolic syndrome patient that we needed to improve. Remember, we said belly fat. So if you're losing weight, I'm sure part of that is your belly. Okay, so weight loss is kind of cool, right? Now, here's our little deal here. Remember how I said it does not lower the blood sugar? You want to remember that. What it does do, if it's combined with other anti-diabetic medication, is increase the risk, because other diabetic medication, especially sulfonylureas, will decrease your blood sugar because it increases insulin production. And that's why this pill and no other pill is for type 1 diabetes, because they don't have a way to produce insulin at all. So if the patient takes this medication, metformin, with other anti-diabetic meds, the risk for hypoglycemia does increase. But here's what you better know. If the patient taking metformin drinks a lot, they really increase their risk for hypoglycemia, because alcohol decreases your blood sugar. It doesn't increase it. It decreases. It makes you really high risk for hypoglycemia. and then you took it with this medicine. And when you took that alcohol, when you're drinking, you're directly affecting the liver. And so here you have a liver that can't do anything but take the alcohol that you're drinking to metabolize it. And it can't do two things at the same exact time. So it recognizes alcohol as a toxin, which it is, and it takes that and metabolizes it and tries to detox the blood. And so while that's happening, it can't store glucose. And here you have this metformin, which already decrease the production of glucose in the liver. And now you took alcohol, which won't allow the liver to even make the glycogen from the glucose. And so you're running around with a very high risk for low blood sugar. Okay, so that's important. So the other thing that I've seen a lot is that after a certain amount of time, the metformin may or may not be working as well. And that's when you see doctors add another drug. Remember that? Okay, so that's important. All right, now, lastly, but not leastly, right? So this is the last part of this video, but it's the most important part because here's where you come in and here's where the reduction of risk or procedures comes in. You will see on your reduction of risk packet that you have, and I just want to show you really quickly. You will see on your procedures, reduction of risk, it's part of your pink packet. Many of you took advantage of the pink packet bundle, right? You took a nice advantage of that. You were smart. You will see on this reduction of risk, and I want to point it out, where I literally put on here not to use metformin. Here we go. I'm going to put it in my fingers. Not to use metformin 48 hours before or after. And right there, you need to write contrast dye. Okay, so here's our issue with the complication of metformin. The number one complication of metformin is lactic acidosis. That is also part of acute kidney injury. So I could sum up the complications and say, you better know it's all about the kidneys with metformin. Okay, so we have a problem though, right? So think about diabetes. Think about pre-diabetes even. Many patients have some kidney involvement when they have diabetes or pre-diabetes, and this treats both diabetes and pre-diabetes, metabolic syndrome. So both patients may have some kidney involvement at this point. So here's what I ask. Did the cart come before the horse? Meaning, did they already have kidney problems to start with that no one knew or tested for? Or did the horse come before the cart, which means did the metformin cause the kidney disease in the patient? So either way you go, this medication is contraindicated with a patient with the GFR, glomerular filtration rate, less than 30. Now you just want to keep in mind, just to keep it simple, that 100 and above is a great GFR. And many of us even say, well, 60 and above is a great GFR. But you need to know 100 is like perfectamundo and above, So this is a GFR less than 30. You cannot take metformin because metformin is excreted by the kidneys. So when you take metformin, the only way to get rid of it is to get rid of it through the kidneys. So then that means anything that keeps or prevents your kidneys from getting rid of it can lead to a lactic acidosis. Watch this. The most important thing is contrast dye. You may or may not have learned in school that contrast dye by itself can be toxic to the kidneys. That's why before we give contrast dye, very often we want to see a BUN and a creatinine on the chart before we even do it. We damn sure better know what the BUN and creatinine are on this patient when they come in for these different tests. So the contrast dye, no metformin 48 hours before or after. And you know what contrast dye is often used for? CAT scans, so be careful. If your patient has had a prolongation of NPO status, they were told don't eat because they're going to get general anesthesia for a certain procedure. Don't eat after midnight, or clear liquids for 2 days and then don't eat, or whatever it is. If the patient has been NPO for hours and hours and hours, they might actually be very dehydrated. So who is that actually is NPO that long? Any patient getting general anesthesia. And so we say that NPO patients getting general anesthesia are at risk for lactic acidosis, okay? Now, alcohol significantly increases your risk for lactic acidosis, not to mention a low blood sugar. How much does alcohol increase the risk? So much so that the FDA put their little black box warning and said no alcohol with this medication, or at the very least, you can't be drinking like you've lost your mind with this med. It's not a great idea. And I say to you, and this is important, nurses, 1 in 6 admissions, 1 in 6 hospital admissions are alcoholics. And I just told you that this medication is given to 1 in 3 people in America, like a lot of people, okay? So you might want to be very careful about this one. Septic shock or any shock will increase the risk of lactic acidosis. And just think of it like this. If you have a patient in shock, you know, I wrote it on page 10 of the Oh My God packet, that all shock has a low BP. And you know that BP stands for blood pressure, or BP stands for blood perfusing kidneys and the rest of your organs. I'm going to say that again. All shock has low blood pressure, BP. BP stands for blood pressure or blood perfusing your kidneys and all the rest of your organs. When you don't have a blood pressure, you don't have perfusion of your kidneys, you don't make urine, you don't clear metformin or contrast dye or anything else. And so we say in CHELLYS Nursing Review, no BP, no PP. Another way of saying that is the patient that has a very low blood pressure because of shock or whatever else will go into AKI. And you remember what we said about words that have a K in the middle. AKI, CKD, DKA. Any of the words with a K in the middle, the K is high, right? Typically. All right, so that was just a hint, okay? Now, how would you know if your patient had lactic acidosis? I mean, it's so rare, but it is fatal. You would know because, you might not know, let me redirect that. You may not know. It's kind of gradual. The patient will be weak. They will be fatigued. They will have flu-like symptoms like body aches and pains. They will have a GI upset with nausea and vomiting. They can even have abdominal cramping. And guess what, y'all? They're gonna have Kussmaul's. What is Kussmaul's? Kussmaul's is what? Fast and deep breathing. But why, Shelly? Because I told you they have acidosis. So how do I blow off acid to compensate for this acidosis? I can breathe fast and deep, which is Kussmaul's. If I breathe fast and deep, I'm gonna get rid of what? Carbon dioxide. And what did I teach you? Carbon dioxide is an acid. So if I'm acidotic, I'm going to breathe fast and rapid, which is Kussmaul's, to get rid of some acid. I hope that's clear. Yeah, so there you go. So metformin, again, is the point of this whole lecture. I do want to point out that metabolic syndrome, which is why we give the patient the metformin, it's really a nightmare, because here's what we know about everybody in America with metabolic syndrome. Here's what we know. 5 times more likely to have diabetes, but 2 times more likely to have a heart attack, and 2 times more likely to have a stroke, and they may already have chronic kidney disease, which is kidney failure in different various stages. So I'm gonna go. I hope that helped. I hope you now know the importance of metformin and holding the metformin when you're talking about contrast dyes. You will find that even when the patient is in the hospital, we don't like to give them metformin as a hospitalized patient. We just don't like to do that on our different med-surg floors because of this issue, the lactic acidosis issue. So anyway, I gotta go. Deuces, have a good day. Talk to you later.